Can I see my my PowerPoint slides? So this is going to be the chapter on heart defects in children. So there is some very specific things that you might see if a child has a heart defect. One of the most important is they might tire when they feed, and they might have a hard time gaining weight. So failure to thrive and also tiring with feeding. They might be blue. They're not always blue, but they might be blue. You might see distended neck veins, increased respiratory rate, and irregular heart rate. Later in time, like if it goes on for a while without being repaired, you could see clubbing of the fingers, which is something you see in general when there's long-term hypoxia. And then, you know, the fatigue with feeding and sweating a lot, excessive perspiration. So, you know, congenital heart disease is more common than I think we think about all the time. It's the most common congenital defect. And when children die from congenital defects, is also commonly from heart disease. So it is something that's important. It affects a lot of kids, and it is a cause of infant mortality. And it's something that most of the time the defect can be repaired. So screening is really important, getting them care if you notice anything that's wrong. And also, just because they have a defect, they can still develop normally when they're inside their mom's body. So there's a difference between circulation outside of the body versus when you're still a fetus or still a baby inside the mom's body, because you're not really using your lungs. You're not using your lungs before you're born. So they don't have the same problems that they have after birth, because they have a different circulation. They have holes throughout their circulation system that allows mixing of blood. So when they have a cardiac defect, it doesn't affect their development inside before they're born, but it can affect them after they're born. They can have problems, and it can ultimately cause death if it's not repaired. And there's, you know, sometimes defects can be pretty simple, pretty easy to diagnose and treat, and they can be more complicated. And also the diagnostic studies can be something as simple as an ultrasound of the heart, which is an echogram, to an angiogram or a cardiac cath. So depending on what they're looking for, you know, the test can become invasive, requiring sedation, etc. So when we talk about cardiac defects, we generally break them down into two broad categories, so cyanotic and acyanotic. So what do you think a cyanotic defect means? What does that mean? If a patient has a cyanotic defect, do they have a normal oxygen level or an abnormal oxygen level?
Abnormal.
Okay, and is it low or high?
Would it be low?
It would be low, yeah. So think about when you have cyanosis, you're blue, you have a low oxygen level. And then acyanotic means that, generally speaking, their oxygen level is okay. When you're talking about defects, this is the general picture of the heart. And I think it's important to always think about where the blood should be flowing. So we're going to start on the right side over here. So your veins bring deoxygenated blood back to your heart, and they drain into the right side. So this is going to be your veins, your venous return coming into your right side. This is your right atrium. This is your right ventricle. And then it goes out your pulmonary artery. And the pulmonary artery is the one that kind of looks like a T. So it goes out the main pulmonary artery, and then it branches off to deliver blood to both lungs. In the lungs, it gets rid of carbon dioxide and gets oxygen. So then oxygen-rich blood is delivered back to the left side of the heart, goes to the left atrium, down to the left ventricle, and then it goes out the aorta. So the aorta is this one here that's curvy, and it has these three output genes. So it's always good to think about, you know, where the blood is flowing normally. And then when you talk about a defect, you see on the heart where the defect is, and you think about how that's going to affect the flow. So I do think it's really important that you can go through your mind and be like, okay, the blood that doesn't have oxygen, it goes to the right side, and then down the right ventricle and the lungs, and then it picks up the oxygen and it goes to the left side. And sort of have that process in your brain, have it make sense to you. And then when we talk about the different defects, it'll make more sense. So we have the two general categories of cyanotic and acyanotic, and then we can also kind of break them down further. Defects that increase pulmonary blood flow, defects that obstruct blood flow in some way, and then defects that decrease pulmonary blood flow. So do you think a defect that decreases pulmonary blood flow is going to be cyanotic or acyanotic?
I'm sorry, did you say cyanotic was
Cyanotic.
normal?
So acyanotic, their oxygen levels should be normal, but cyanotic, it's low.
Okay, so that would be cyanotic.
Right. So if you're not having enough blood flow go to your lungs, very good. You're not going to have enough oxygen level because you get your oxygen in your lungs. Very good. So then there's something else that's important when we talk about cardiology, and that's this concept of a shunt. So shunt just means blood flowing through an abnormal opening of the heart. The ones that we talk about frequently is going to be an ASD and a VSD. So if we go back to this one here, both sides of the heart have what they're called atrium. That's the top chamber. So an ASD is a hole between the right atrium and the left atrium, and a VSD, or a ventricular septal defect, is a hole between the right ventricle and the left ventricle. So these are the two primary holes that we're talking about. So when a patient has a shunt, that means that blood is flowing through that hole, either the ASD or the VSD. And it always goes through high pressure to low pressure. So, and the left side of the heart is high pressure because it's bigger. If you look at it, it looks a little bit bigger, and it is a little bit bigger because it has to pump out throughout the entire body. So the right side just has to get blood to the lungs, but the left side has to pump the blood to the entire body. It's a little bit bigger, it's a little bit stronger, it's a higher pressure. So when you have a shunt, it will go from left to right because it goes from the high pressure to the low pressure. So if you have a hole in your atrium, so between your right atrium and your left atrium, and you have a shunt from left to right, do you think that increases pulmonary blood flow or decreases pulmonary blood flow?
I think it decreases.
Okay, we got one for decrease. Who else has an opinion? I see you thinking, Reese. What do you think? If you have blood on your left side of the heart and it moves to your right side of the heart, are you going to have more or less pulmonary blood flow?
More.
More, because you have more blood going to the right side of your heart.
I was gonna say more. Okay.
Yeah. So if you have a shunt, if you have a left to right shunt, ASD, VSD, and we didn't talk about it, but also the PDA. So the PDA is going to be here. The PDA is the patent ductus arteriosus. So it's where the pulmonary artery and the aorta cross. There's a hole there for fetal circulation to allow mixing of blood. So you can shunt at the PDA, which is here where the two great vessels, you can shunt at the atrial level and you can shunt at the ventricular level, and they'll all be left to right. And all of them increase pulmonary blood flow because you have more blood moving to the right side of your heart, which ultimately goes to your lungs. So this next slide here, it shows you where the blood is going for different defects. So this is normal, coming into the right side, going out from the right atrium to the right ventricle to the lungs. And on the left side, you're getting blood flow from the lungs, going to the left atrium, left ventricle, out to the body. And this is your atrial septal defect, shows your hole here between the two top chambers of the heart. And as we talked about, you're seeing some of this blood come over, and then this is increasing your pulmonary blood flow because some of the blood from the left side goes over to the right side and ultimately goes to the lungs. And the same thing with the VSD, except it's the lower chamber, so the blood's going across here. And this is the patent ductus arteriosus, where we talked about, that's where the pulmonary artery and the aorta cross, and it's the same thing, left to right, increased pulmonary blood flow. This one is coarctation of the aorta. So this is, the blood flow into the heart is normal, and then out normal up until the point you get this narrowing. So this is this main vessel that takes blood out to the body from the heart, and it's narrow here. And then tetralogy of the flow is one of the more complicated ones, but I know there are always test questions on it. So there are 4 characteristics of tetralogy of flow. There's a VSD. There's something going on with what's called the right ventricular outflow tract. So you see narrowing here. There's right ventricular hypertrophy, where it's bigger here. The right ventricle is bigger. It doesn't really show it here, but there's the atrial septum, or the line between the chambers of the heart is moved over. It's deviation of the atrial septum. So this one it's more complicated because there's more things going on, but you can see there is some blood flow moving over, but then there's also restriction of blood flow to the lungs because of this narrowing. So this is what we just talked about. So when you have those shunts, the oxygenated blood recirculates to the lungs, and it's very, very rare for there to be any cyanosis or any blueness because they're getting extra blood flow to their lungs. So these ASD, VSD, PDA are not associated with cyanotic spells. So this is just a quick snapshot of the cyanotic and the acyanotic. The one that we talk about the most in terms of the cyanotic is going to be this tetralogy of flow. It's one of the more common defects, and it's one of the ones that are most tested. So I would definitely say that you should pay attention to that defect, and you should know what the 4 characteristics are and how it's treated. And we'll talk about it more, but this tetralogy of flow, this is a heavily tested topic in nursing world. So this baby obviously doesn't have a very good color. So a lot of defects are associated with cyanosis, but they're not always. So just remember that you can't rule out heart disease in a baby or congenital heart disease if they have normal color. They're not always blue. So restrictive, just as the word suggests, it means there's some sort of narrowing. The one that we talk about the most is going to be the coarctation of the aorta. So what do you think? If you have a narrowing in your aorta, so I'm going to go back all the way to this one here. This is your left ventricle, and this is your aorta, and you're going to have narrowing here in this part that's going down. So these vessels that come off the top, they're going to your head and your arms. And this lower part is going to bring blood flow down to your lungs and the lower part of your body. So if you have a narrowing in the aorta, is the blood pressure in your legs going to be high or low?
I think it's low.
It's low. And that's one of the things that you need to remember when you're trying to figure out what's going on with your patient. If there's a discrepancy in the upper extremity blood pressure versus the lower extremity, one of the things you worry about is that they have a coarctation. So do they have good pulses? Can you feel their pulses really well on their feet if they have a coarctation of the aorta? No, right? Because their blood, that big vessel that's bringing the blood down there is narrow. And so they're not going to have the same blood pressure. They're not going to have the same pulses and perfusion. So this is the primary characteristic that you'll see is a narrowing of the aorta causes this marked difference in the blood pressure. And this is the picture again that shows here that it's narrow. Depending on how narrow this area is, sometimes kids are diagnosed. I've had kids that were like 14, 15 years old when they were diagnosed. They're not always diagnosed as children. They can live sometimes for many years without being diagnosed. That's rare, but it can happen. Usually kids are repaired, around 2 to 4. So, especially in the upper extremities, it can cause high blood pressure. It can cause congestive heart failure because the heart is having to pump really hard against that narrowing, and they can end up with an endocarditis or an infection of the heart. So, they sometimes they can balloon that area, or sometimes they have to surgically cut it out. cut out the narrowing and then sew the two ends back together. Sometimes they're hypertensive coming out of surgery, so they need hypertensive drugs. They might need steroids, and they frequently, almost all cardiac surgeries coming out, they have an NG tube down to decompress their stomach until their blood flow is regulated and normal back to their intestinal tract. So you guys were spot on when we were talking about this earlier. The defects that decrease pulmonary blood flow, there's two main ones: the tetralogy of Fallot, which is the one that's a little bit more complicated, and then pulmonary stenosis. And pulmonary stenosis is just narrowing of that pulmonary valve. But as you said, if they're not getting enough blood flow from the right side of their heart out to the lungs, then they'll be a little bit blue. So this is the breakdown again of the tetralogy of the Fallot. With it has the pulmonary stenosis, right ventricular hypertrophy, overriding aorta. So it's overriding the septum, and then the ventricular septal defect. So it has these four characteristics that makes it be tetralogy. Tetra is for four. So this is one that's sometimes like coarctation, kind of depending on how severe it is. Sometimes they're not diagnosed right away. So sometimes these kids, usually they're diagnosed in infancy, but sometimes they will be a little bit older. So, you know, the longer they go, the more cyanotic and the more problems they're going to have. So the clubbing of the fingers, this is something you're going to likely see if they were a late diagnosis. And then they sit in this squatting position. This is very common, where they squat like this. They just exactly like that picture. And what that does is it pushes more blood flow back to the heart. And if they get more blood flow back to the heart, more of it will go to their lungs. So they'll automatically do this to try to increase their pulmonary blood flow. And like other cardiac defects, they can have feeding problems, low or inappropriate rate of growth, and etc. They can have some dyspnea. And then polycythemia. Does anyone know what polycythemia means? So does poly
That's
mean
when
more?
the red blood cells are replicating too quickly.
Very good, Reese. Yes. So why? Why do you think someone who's chronically hypoxic would have an increase in their red blood cells?
To compensate.
To compensate, because your red blood cells carry oxygen. So if you're not able to get enough blood flow to your lungs to pick up oxygen, your body compensates by producing more red blood cells. Toxic, but you have more red blood cells available to carry oxygen. And it's something your body does on its own. It automatically starts producing extra red blood cells to compensate. So hypercyanotic spells are also called TET spells. And they can actually like pass out. They become very blue. And then when they're kind of coming out of it, they can be very lethargic and sleepy. So this happens when they're not getting enough blood flow to their lungs. And what you do is you put them in the knee to chest position, put them on their back, and you push their knees into the chest. They'll do it kind of on their own instinctively, where they'll squat. But if they have a TET spell and they go limp and blue and you're taking care of them, they'll be on their back, and you push their knees into their chest. That's the main treatment for a TET spell from a nursing perspective, is you push their knees into their chest, and that increases their venous return, and then that extra venous return should go to their lungs and they should pick up some more oxygen. So this PowerPoint slide is really long, so I'm just going to kind of point out some things. There are some specific complications that can go along with having heart defects. So if you have polycythemia, etc., then you're more likely to form clots. So you're naturally produce more red blood cells when you're hypoxic, but then that sets you up for increased clot formation. Sometimes they can have the opposite, iron deficiency anemia, because they're not eating very well. So they're not getting all the nutrients that they need and they become anemic. All of these holes, problems with their valves, etc., that's a place for bacteria to grow so they can have bacterial endocarditis. Almost always they're going to need surgery. There are some things that they can do in the cath lab, but most congenital heart defects are repaired in the operating room. So this one here, hypoplastic left heart syndrome, which you'll see it sometimes written as HLHS, is probably the most complicated heart defect. And they don't tend to be a ton of questions on it, but it's something that you need to recognize. So does hypo mean small or big? So when you say hypoplastic left heart syndrome, is the left side too big or is it too small?
Small.
Too small.
Too small. So it's an underformed left ventricle. There's usually problems with both the aortic and mitral valve, which are the valves on the left side of the heart, and then also the aorta is too small. So all of the structures on the left side of the heart are too small. So the left side of the heart is the chamber that pumps to your body, right? It gives you the blood flow to your brain, to your internal organs, to everywhere. So these kids are terribly sick until they have at least their first surgery because they don't have a good pumping chamber to get their blood to their brain, to their stomach, wherever the blood needs to go, because the left side is the side that's responsible for getting blood to the body. So this defect, it's called a ductal dependent defect. They're referring to the opening between the pulmonary artery and the aorta. So in order to maintain their blood flow to their body, they actually steal blood from their pulmonary artery. So you need to keep that opening between the pulmonary artery and the aorta open in order for them to have adequate blood flow to their body. So this kid will be on a medicine called prostaglandin, which keeps the duct open until they have a surgery. So prostaglandin E. So there are some, in terms of the hypoplastic left heart syndrome, there are some key things that I remember. It's complicated, it's ductal dependent, so they require prostaglandin when they're born. And it involves just general small structures on the left side of the heart. And it is one of those defects that sometimes they go directly to heart transplant. So if they're diagnosed before they're born, if they're diagnosed in utero, sometimes they'll be listed for transplant, they'll be kept on prostaglandins, and then they'll go for a transplant surgery as an infant. So just kind of thinking about all the different things that could go wrong with the cardiovascular system, there's certain things you need to make sure you're monitoring for, you know, their vital signs, their weight, how they're eating, their color, you're doing their neurovascular checks. They require a lot of monitoring at infant care. And most of the time, these kids are in specialized units in the hospital that with nurses that have additional training in cardiac defects. So you worry, you know, you can see increased heart rate, so tachycardia and tachypnea. They don't grow as well, can have problems breathing, tire easily, and, you know, frequent URI infections. So not all defects are diagnosed before they're born, so you kind of have to be on the lookout. If you have a kid that's kind of scrawny, not gaining weight well, seems to be having a hard time breathing, kind of consistently has an elevated heart rate, you should have on your radar that they could have an undiagnosed heart defect. So in addition to congenital heart disease, you can have acquired heart disease. So, you know, this is something that's obviously more common in adults where they have like coronary artery disease or hypertension that leads to problems with their heart, but it's not as common in kids. Usually for kids, when they have heart disease, it's congenital or they're born with it. But you can have an acquired heart disease, you know, as response to, you know, infections. You can end up with like a endocarditis. Strep throat can cause something called rheumatic fever that causes valve disease. So occasionally kids do develop acquired heart disease. And generally speaking, heart failure is just a decrease in cardiac output, and then you're not able to meet the metabolic needs of the body. So I think you guys have probably, has everyone taken med-surg, or is med-surg taken simultaneously with peds?
We did
Med-surg
med-surg 1 and med-surg 2. We're on med-surg
Okay.
2 right now.
So have you guys talked about left-sided heart failure versus right-sided heart failure? And do you feel like you could pick out the differences between the two? Or is that covered in med-surg?
Yeah, we did that in
Yeah.
med-surg 1.
Okay, so I won't spend too much time on it, but you know, it's the same thing with kids. You can, your type of heart failure that you have is going to depend on where in the body, you know, so left-sided heart failure, you're not your left chamber, your left ventricle that goes to your body, and then it's going to be the blood flow is going to back up into your lungs. So then you're going to end up with the pulmonary congestion is one of the main things. And then the right-sided, you end up with the venous congestion. You're not really able, your right side isn't able to pump effectively to your lungs. So then the right side backs up and you end up with this venous congestion. You can have ascites, swelling in your legs. You're more likely to have kind of those GI complaints because you're not having good venous return back to your heart. So, you know, you should be on the lookout. Like I said, not all heart disease is detected in utero. Sometimes kids go home from the hospital and they have a heart defect that wasn't detected. So you should be able to recognize early signs of congestive heart failure in infants. So that's going to be tachycardia at rest, fatigue during feeds, sweating kind of more than you would expect, the hard time breathing, and could be sudden weight gain. So you know, when you're going into heart failure, you become edematous. But the ones that, you know, so I would definitely recognize all of these and be able to pick them out, like a select all that apply on an exam. What are the signs of congestive heart failure in infants? And the sort of the thing that you really will see frequently being tested is that babies with heart disease tend to have a hard time feeding. They tire out when they're eating. So generally speaking, if you have a patient with heart failure, you want to decrease the workload of their heart, improve their lung, make it easier for them to breathe, make sure they're getting good nutrition, prevent infection. So it's not unusual that kids that have heart disease before they're fully repaired, they're on higher calorie formula, or they're meeting with a nutritionist that help them make sure they meet their nutritional needs. So if they're, you know, in the hospital and you're caring for them, you really want to give them as much rest time as possible, because they need all the time they can to rest, because having heart disease burns a lot of calories and is really stressful for them. So you want to bundle your care. You don't wake them up to feed them, small, frequent amounts. You might have them on oxygen. They're almost always on medications. Make sure they're given on time. And you want to do accurate eyes and nose. These are some basic things that you're going to be doing for any baby that has a heart defect. So rheumatic fever is one of those acquired heart diseases that you might see in children. Has anyone heard of rheumatic fever? Okay, so we don't see it a bunch in the United States, but worldwide it is definitely a significant problem. And you need to remember, this is the one that's, it happens after an untreated or improperly treated beta hemolytic streptococcus infection. So this is going to be the bacteria that causes your strep throat. So this is why it's really important that if you're diagnosed with strep throat, you take the full course of the antibiotics. And if kids have a sore throat, that they get the strep test. So this is an autoimmune reaction after they've had a strep throat infection. So there are some specific things that go along with rheumatic fever. So chorea is unusual muscle twitching, uncontrollable muscle twitching. It can be your face, it can also be your hands. Carditis is inflammation around the heart. This erythema marginatum is this rash that's associated with rheumatic fever. They can have joint pain and swelling, fever, enlarged lymph nodes, and abdominal pain. There's a very specific criteria called Jones criteria that's used to diagnose rheumatic fever. And they have what are called minor and major criteria. You don't need to memorize all of these. I would say that you should recognize some of the key words that are a little bit different, like chorea, which is that muscle twitching that's unusual, and the erythema marginatum, which is the rash. These are things that you don't really see with other illnesses that are more specific to rheumatic fever. And then, to be diagnosed, they have to have 2 major criteria or 1 major and 2 minor. And the slide before it goes over the different ones. Like I said, I wouldn't spend too much time memorizing all the different criteria. It's more important to know that it happens after strep throat. It's autoimmune. And so that's why it's really important to adequately treat strep throat infections. So if they develop rheumatic fever, then they have to be on long-term antibiotics. They have to be on something like penicillin for several weeks, or I'm sorry, for 5 years after their treatment. So they're going to be on antibiotics for years after they're diagnosed with rheumatic fever. So you do a lot of the same sort of care that you do with other kids that have something that you need to remember. This specifically influences or affects their valves. They end up with endocarditis on their valves. So they do need to have antibiotics, prophylactic antibiotics, whenever they have dental therapy once they've been diagnosed, because when you're messing in with the mouth, it can seed bacterial into your bloodstream. They can then go to your heart and cause endocarditis. So the main thing that you need to do to prevent rheumatic fever is make sure that kids are getting tested and treated for strep throat, and that the parents remember to complete the full course of antibiotics. So sometimes kids will develop hypertension. It's not as common in kids as it is in adults, but we need to be checking blood pressure in kids, and they can have it. So if it's persistently above the 95th percentile for their age, and there'll always be like a breakdown of age for their blood pressure, then you need to be concerned about hypertension. So primary or essential means there's not another disease process that's causing the hypertension. So for example, if you have a problem with your kidneys and you have fluid overload, and that causes your high blood pressure, that's secondary to your kidney disease. But if you have primary hypertension, that just means that then the cause of your hypertension is unknown. It's not caused from another disease process. What do you think we start with if it's primary hypertension? Do we give them a medication right away if they're a kid, or what do we normally do to treat their primary hypertension? How often do you see kids on blood pressure medication? Not very often. So what do you think we start with?
Diet, maybe?
Diet and exercise. Very good. So yeah, there's certain things that kind of make kids more likely: obesity, bad diet, inactive, and then also children that have parents who have hypertension are more likely to have hypertension themselves. So you guys were spot on. So nutritional counseling, weight reduction, moderate exercise, start with some sort of an exercise program. And then if they have secondary hypertension, like kidney disease that caused the hypertension, then your primary thing is you also make sure you treat the kidney disease. So non-pharmacological things: aerobic exercise, weight reduction, diet management, adequate intake of potassium and calcium, but you don't want too much sodium, no smoking, the same sorts of things that you would recommend in adults. So there will be some information on your quiz and on your test about the cholesterol. So does anyone know the difference between HDL and LDL? Which one is the good cholesterol and which one is the bad cholesterol?
Is HDL, that's the one you don't want to keep too high, right? No, the LDL is the one you want to.
Very good. So the HDL actually takes the cholesterol to your liver and processes it. So it lowers the amount of cholesterol that can go to your arteries. So the LDL, it carries your cholesterol to your blood vessels, and that's where you get your plaque development. So having a high, like the ratio, if you're having too much LDL to HDL is a problem. So your LDL is the one that contributes most to your plaque formation, and it has a higher amount of cholesterol in the molecule. So the HDL is the good and the LDL is the bad. So Kawasaki's disease is it's not specifically a cardiac disease, but it can cause coronary artery disease. So it is a cause of acquired heart disease in children. And it's not clear what causes it. Sometimes people think it could be related to like the shampoo that people use to wash their rugs. It might be a reaction to an infection. So the exact cause is unknown, but it tends to occur in young children. And there's some very specific symptoms. I'm going to go here. They tend to have like this very, very like bright red strawberry tongue. They have this rash. Their eyelids are really, really red. So it's like a vasculitis. Their vascular blood vessels are inflamed, and there's, you see the bright red eyes, etc. So these kids tend to have really, really high fever, up to 104, and it doesn't really come down with Tylenol, Motrin, and antibiotics. Like that's the normal thing that you start with when a kid has a high fever, and it lasts for more than 5 days. And then they have the red eyes, the dry cracked lips, that strawberry tongue, and it's, you know, it's kind of a diagnosis of exclusion because there's not a specific test for it, but this is kind of what they look like when they have the Kawasaki's. And then they, this goes over it in a prettier picture. So it's treated with gamma globulin, so IVIG. And this is one of the only times you're going to give aspirin to a kid that has a fever. So why do you think you would give aspirin? Does anyone know, like, you give aspirin, who else gets aspirin? Who else do you recommend giving aspirin to?
It's a blood
Is
thinner.
it not to thin the blood?
Yeah, very good. So this Kawasaki's disease can cause coronary artery disease in children. So you give the aspirin for that blood thinner effect because they can have developed coronary artery disease. So salicylate therapy, that's the family, the aspirin family, and then warfarin is also, it's another anticoagulant. So they usually start out with aspirin, but it's not unusual that they'll go home on warfarin, which is also called Coumadin.
I have a question.
Yeah.
So we're giving children aspirin, so then do we worry about Ray's disease?
Yeah,
syndrome or whatever?
Yeah, you do. You have to worry about it. So this is really the only case when when the risk versus benefit is you're going to go ahead and give it, but you have to monitor for it because they could, right? Yeah. So very good. Was that Reese? Yeah. That's what we talked about last week. Yeah. So this is why it's one of the only times when you're going to do it. And it's specifically because of you can give it quickly, it's available, and it has that anticoagulation therapy for their coronary arteries. So usually with Kawasaki's, it doesn't relapse, it doesn't come back. They're pretty sick. They get their IVIG, their IV therapy, their supportive care, and then it eventually gets better. They can develop the coronary artery disease, so then they may or may not end up on the low dose aspirin therapy. So I know that's a lot of information. I feel like cardiac in kids, the defects are very specific to kids. So I hope that it made sense to you. If for some reason it didn't, please go over the PowerPoints and then let me know if you have any questions. And then we're going to do a little bit of a Kahoot because I want to make sure that you guys are ready for your quiz next week. So I would say when you're studying for your quiz, I'll post the Kahoot. I would pay attention to the Kahoot, and then I would just kind of review the PowerPoints. If you do that, you should do fine.
You're muted.
Thank you. So I'll let you guys lead this, the first one. Thank you for telling me though. All right, so yeah, very good. This is the one that can cause rheumatic fever. So you need to make sure you're treating it with antibiotics for 10 days. So which congenital heart defects cause increased pulmonary blood flow? ASD, VSD, PDA, tetralogy, aortic stenosis, pulmonary stenosis, coarctation of the aorta, pulmonary stenosis, VSD, VSD, aortic stenosis, tricuspid atresia. Yeah, so it says ASD, VSD, PDA. These are the three that there's a hole in the heart and there's a left to right shunt. And then you're going to get more blood flow from the left to the right. And that extra blood flow that goes to the right side will go out to your lungs. So like this one here that says TOF, tetralogy of flow. That's the one where there's a narrowing of the pulmonary valve, and so is pulmonary stenosis. So I just remember you're definitely going to have to be able to break these down. So these are the three. There's a left to right shunt, and that causes more blood flow to go to the right side, which then ultimately goes out to the lungs. So a child swallows frequently after a tonsillectomy and adenoidectomy. What might that indicate? Vomiting, pain at the incision site, bleeding from the surgical site, or a sore throat from a postnasal drip. So we didn't get into the respiratory stuff because we just didn't have time after the exam, but this is something that you need to make sure that you remember. Kids after TNA, if they're swallowing a lot, they could be bleeding at their surgical site. So that's one thing that you have to monitor for, and make sure you tell the doctor if you're seeing that when they come out of surgery. So what should the nurse explain to a parent of a child with exercise-induced asthma? So I'm not going to lie to you. I don't like this one, so I'm going to skip it. Okay. So the parents of a 3-month-old with cystic fibrosis want to know how their child got the disease because neither parent has CF. Only one parent carries the CF gene. The inheritance pattern is multifactorial. Both parents are carriers, or the result is probably a genetic mutation.
I can't, play.
What'd you say, Walter?
My thing is acting up. I can't even answer anything.
Oh, I'm sorry,
Oh.
Walter. I'll post it in there so you can practice on your own, but please pay attention for the rest of the
Yeah,
class. Okay. Okay. So this one, most genetic conditions, if neither parent has it, then they're both carriers. So this is something to kind of remember. This is going to be true with most things. If neither parent has it, then they were carriers, and that's the kid got the recessive gene from both parents. So which fluids are most appropriate for a 5-year-old child with asthma experiencing dyspnea and fluid loss? Carbonated beverages, iced fruit juice, room temperature water, or cold milk? All right, very good. So you don't want to do something that's really cold that can cause bronchospasm, make it worse. And carbonated beverages could be irritating. So the room temperature water is the best option. So why are patients who use dry powdered inhalers for asthma instructed to rinse their mouthpiece? So to prevent discoloration of their tooth enamel, to prevent candidiasis, protect against irritation of oral membranes, or prevent halitosis, which is bad breath.
Coloration.
So yeah, it's the prevent candidiasis. This is the thrush. So they need to make sure that they're cleaning out their mouthpiece if they're shaking up the inhaler. That's a dry powder, which would be something like Advair. So how long after smoke inhalation injury are patients at greatest risk for pulmonary edema? 72 hours, 4 hours, 18 hours, or 2 hours? Wow, I'm impressed. So this 72 hours, you guys should remember, this is peak inflammation for just about anything. So you can expect inflammation three days out from a head injury, anything that causes inflammation in the body. You might not see that full inflammation for 3 days. So which initial intervention will the nurse suggest to the parents of a child experiencing a barky cough? Bring the child to the emergency department, take the child outside in the cool air, use a humidifier or take the child into a steamy bathroom, or have the child drink plenty of fluids. All right, so very good. The humidifier, barky cough, what is that associated with? Does anyone know? Has anyone had kids before that had a barky cough?
Group.
Croup. Very good. So you do want to take them, the steam, the moisture can help calm their airway. Very good. So which findings are expected when measuring the blood pressure on all 4 extremities of a child with a coarctation of the aorta? Blood pressure will be lower in the arms and in the legs. It'll be higher on the left side, higher on the right side, or it'll be lower in the legs. Yeah, so this is the one where it's going to be lower in the legs. We talked about like the aorta is that big vessel that takes it to your body, and it tends to have the narrowing after it branches off to deliver blood to your upper body and your head. So you do expect it to be lower in the legs if they have a coarctation. Also with decreased pulses and perfusion in their legs. Why do children with tetralogy of Fallot favor a squatting position? It decreases arterial blood flow away from the heart. It's a common resting position when the child has a tachycardia. It increases venous return back to the heart or increases the workload of the heart. Very good. It increases the venous return, and then ultimately that'll cause more blood flow to go to their lungs. So which comment by the parent of a 1-month-old infant would concern the nurse about a possible congenital heart defect? He sleeps all the time, he tires out during feedings, he's fussy for several hours a day, or he's always hungry. Yeah, so this is one of those main things you see in kids that have heart disease is they tire out when they're eating. So through what does the infant born with hypoplastic left heart syndrome acquire oxygenated blood? The ASD, the patent ductus arteriosus, a VSD, or the closure of the foramen ovale? So it is this patent ductus arteriosus, which is where the duct that's between the pulmonary artery and the aorta, and there's a very specific medication called prostaglandin that keeps that duct open. So the hypoplastic left heart syndrome is what's called a ductal dependent lesion. They need to have that opening between their pulmonary artery and the aorta. When it closes, they can die. A child recovering from rheumatic fever needs to receive monthly injections for 5 years of what medication? Prednisone, penicillin, Benadryl, or Zosyn? So it is the penicillin. This is the one where they have to be on an antibiotic that treats the strep throat for 5 years after they're diagnosed. So the nurse should prepare for emergency intubation when caring for a child with what diagnosis? Asthma, bronchiolitis, epiglottitis, or Kawasaki disease? So since we didn't get into respiratory, I'm not surprised you didn't know this, but you need to remember this 100%. You'll be tested on this again. Epiglottitis is narrowing of the airway right where the voice box is. So it's an upper airway obstruction and it's a medical emergency. These kids come in, they tend to be tripod posturing, drooling. They can't swallow their own secretions. And if you suspect epiglottitis, you need to prepare for like an emergency trach or an emergency intubation with an anesthesiologist. So you definitely need to remember the name of this diagnosis because you'll see that again on tests. How do you treat primary hypertension in a child? Encourage moderate activity, give Lasix at bedtime, encourage a diet high in salt, or refer to an endocrinologist. Very good. This is where you're going to start with your diet and exercise if it's primary hypertension. So you're going to encourage moderate activity. So an infant with a heart murmur and failure to thrive will likely have what diagnostic test first? An electroencephalogram, a cardiac catheterization, electrocardiogram, or an echocardiography? So the echocardiography, that's just going to be the ultrasound of the heart. That's usually the first thing that they do to try to see. They can see, you know, the defects there because they get the pictures of the heart. All right, last one. Dun, 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 dun. What is the difference between HDL and LDL? HDL reduces the risk of plaque buildup. LDL increases the risk. They are the same thing. HDL is a protein and LDL is a lipid. HDL is higher in cholesterol than LDL. Right, very good. So HDL is your good one. It actually helps you get rid of cholesterol by taking it to your liver. So it decreases your risk of plaque buildup.
I remember.
All right, Samantha and Helene and Marissa, good job, everyone. I know, you know, we didn't do the respiratory chapter, but I wanted to make sure you guys had some key points to make sure you follow up on in your book so everyone was ready to go for their quiz next week. So please remember that there is quiz next week. So it'll be over this week's information, cardiac and respiratory. So it won't be over any new information and we'll take it at the end of class. Does anyone have any questions? Okay, good luck, everyone. I'll post the lecture and the Kahoot and everything in the announcements. If you guys have any questions, let me know. Have a good week.
Two.
Bye-bye.